for people who might just all of a sudden be diagnosed with a horrible disease. And if you have symptoms or you have issues, you are welcome to access palliative care. Okay? It doesn't necessarily need to be home-based care. You might not need home-based care at that time, but there are different aspects of palliative care, either in a hospital setting, as an outpatient, through your family doctors who might practice it, or in my case, for people who are now getting it's now a little bit more challenging to get out. Okay? So what is not palliative care? So it is not just end-of-life care. I cannot say this enough. We do not any longer take care of people at the very end of life. We take care of people much earlier on in the prognosis for themselves, so that, as I said, they can live the best life. It's not about giving up, because in the past we used to think like you're in palliative care, there's nothing left for you, there's no further treatment. But the philosophy today is that there is an opportunity to go and have whatever treatments you need and continue to have palliative care, or to start having palliative care as a manner of managing pain and symptom issues that arise as you go through your treatments. So this is why I say it's not end-of-life care. It's not when you're finished with chemotherapy or whatever other treatments you are having. It can coincide with all of them. Okay? And it's not the same as hospice care. Hospice care is more a component of palliative care, which is more end-of-life related care. So when you hear about hospice care, that's often what people are referring to. Palliative care, hospice care is a component of palliative care at a particular time in the prognosis, but it is not the whole aspect of palliative care. So I want to actually hone in on hospice care, because it's very different in Canada than it is in the United States. So we'll talk about United States first, because in the United States, hospice is a Medicare formulation where you have a criteria you have to meet, and if you meet that criteria, money from Medicare is paid to an organization that will provide hospice care. So when you hear about people who are in hospice, or that terminology, they're referring to an American terminology. They've entered hospice care, which is a financial organizational care that's provided through different private services that take money from Medicare and give it to people. It's a private service, usually through Medicare, so the companies that do it are private. There are very significant restrictions on the types of medications that can be used, the types of care that can be used, who can get it. And it's mostly home-based care. In Toronto, hospice care means one of two things. So you can resort to hospice, and there's two types. There's the volunteer hospices. So those are the volunteer organizations that provide additional support to families and patients who have a life-limiting ailment. So if you were somebody who is caring for somebody with dementia, and you are feeling all isolated, and you don't know what to do, there are organizations called hospices that you can access that will provide you with volunteer support, talk support. Some of them will even bring a masseuse to your house so that you can get a massage. It's a volunteer support system that you don't pay for. So that's the volunteer hospice. The second type of hospice in Ontario or Toronto is the residential hospice. So you might hear like palliative care units, hospice. What's the difference? A palliative care unit is usually in a hospital setting. A hospice is usually in a home-based like setting. So it's not your own home, but you go to a place where they have private rooms and a little kitchen and a little living room, and nurses are there 24/7, and doctors come in and they take care of people at the very end of life. So that is your residential hospice. So you can see that in Canada, Canada, we don't have that designation of like, you go into hospice. That is an American creation. In Canada, hospice care is either volunteer supports that provide you with care, or it is where people will go for truly end-of-life care if they can't be at home and they don't want to be in a hospital. The palliative care unit and the hospice, they do the same kind of care. It's not significantly different. They call it hospice because it comes from like the British system where you're in a home-based like setting that is warm and kind and tender. And so people who want that will go to a hospice as opposed to going to a palliative care unit. Does that make sense to everybody? So let's go back to the history of palliative medicine in Canada. We're going to do it really quickly. Canada is actually one of the countries that has been at the forefront of palliative medicine. In fact, the term palliative was coined by a Canadian. So Dr. Balfour Mount was a Montreal surgeon who started to think about how little care there was for people at the end of life. And he ended up going overseas to the United Kingdom, where they had their first hospice system. And he met with a woman named Cicely Saunders, who was a nurse who became a doctor, who started taking care of people at the end of life. And he learned from her, and he came back to Canada, and he opened up one of the first hospital-based palliative care units in Canada at Royal Victoria Hospital, for any of you much know. And his philosophy was palliative care is not about dying, it's about living well until you die. Which is why I say to people all the time, like, there is still a lot of living for you to do, so let's figure out how we can do that, right? And so he actually coined the term palliative care, which actually means, is a Latin word, it's based on a Latin, which means to cover or to cloak. And the notion was to care for the most vulnerable people by covering them or caring. So palliative care terminology is actually a Canadian creation. So how has palliative care changed? Because you're sitting there probably and you're thinking, well, I really thought that palliative care was really just end-of-life care. When did this all change? So it actually changed in the last 25 years. So in the 1970s to 1990s, palliative care was really truly end-of-life care. People were referred in their final weeks of life. It was mostly for patients with cancer, and it was triggered by uncontrolled pain or intractable symptoms, and there's nothing left for us to give you, and we have no further treatments for you. You're going somewhere to die, and this is what palliative care is. But the research has actually shown that as people get palliative care early on in their diagnosis, they do better. So there's been some research in early 2000 that said, if you compare patients who are just diagnosed with lung cancer, who get palliative care at the diagnosis, and people who are diagnosed with lung cancer who don't, the people who got the palliative care actually lived longer. So it's not about doing something that is going to hasten this process for you. It is about really doing something that is going to provide support. In addition to that, we actually realize that there's a lot of people out there, other than just cancer patients, who need this support. People with dementia, with heart failure, with kidney failure, with lung diseases, ALS, other neurological problems. And so a new focus has been created on caring for people without cancer. So there's actually a group of people that I've spoken to, a group of doctors actually that I've spoken to before, and they are specifically palliative care for non-cancer patients. And most hospitals in the city right now are trying to focus on them. So when I was in Sunnybrook, my specific focus was on patients with ALS and patients with heart failure. And I was embedded in these different clinic programs where I was providing care to these people, because ultimately we don't have cures for them. We can keep people as well as we possibly can for as long as we can, but there is no official cure for heart failure. We do our best, and people can live years and years and years so nobody get worried here. I'm not suggesting the end is nigh. I'm just suggesting that we know that there is nothing that we can do about curing heart failure. We can't cure hypertension. We can't cure diabetes. Like, there's many things that we can't cure. But what I'm trying to say is that palliative care, as a result, has moved what we call upstream. So we're now taking care of the people early on in the diagnosis, as I was saying, so that we can allow them to live the best that they possibly can. Does that make sense to everybody? And so now that you are kind of sitting here saying, oh, who knew? Let's talk a little bit about the benefits of palliative medicine for patients, all right? So we know that it's better for controlling disease symptoms. Pain, nausea, vomiting, shortness of breath, constipation, diarrhea, sleep issues, depression, anxiety, like all of those things are my bread and butter, right? So we know that we're better at controlling disease-related symptoms. It also improves quality of life, and there are definitely, from a research perspective, you can ask, well, how do you gauge quality of life? There are research questionnaires that have been shown to show or prove an individual's quality of life, and when you look at those who have palliative care versus those who don't, they are better off, and they feel better off. It's a more realistic illness understanding. I cannot tell you how many times people have said to me, I have no idea where my disease is headed because my so-and-so doctor won't tell me. And it's our job to be able to have these conversations in a nice, gentle, realistic way that provides you with the information that you can make decisions for how you choose to live your life down the road, right? This is about being able to figure out what your values are, how you want to die, what you choose to do to live the best that you can, and then we're able to meet those needs, which is why people who receive palliative care are feeling less anxious, less depressed, and more comfortable, emotionally. And lastly, keeps you out of the hospital. And if you do end up in hospital, you stay in hospital for less time. Keeps you out of the ICU, keeps you out of the emergency department, and who wants to be there? I certainly don't. So, in other words, you get to stay as much as you possibly can in your homes, if that is what your wishes are. And it keeps you out of ICUs and ERs and those kinds of things. But it's not just patients that it benefits. Benefits to families and caregivers. We help with coaching and advocacy for them. It lowers caregiver distress. So the research actually shows that when a family member has palliative care, caregivers experience less grief after they have passed, less anxiety, and less guilt. And I don't know about you, but like from my perspective, guilt is one of the worst things that people can experience. And so that is like a humongous benefit. It provides more comprehensive support, and you are then able to also align yourself with your loved one's wishes. Your loved one will tell you, oh, I don't ever want to go back to the hospital again. And then if that ever comes up, you can actually advocate that for them. So sometimes you never even have these conversations. And I can't tell you how many times I've gone to somebody and like, have you ever thought about what your wishes might be, ... And they're like, nope. And they're, 85 years old, but it's never been something that they wanted to talk about. It's never something that anybody has talked about with them. But then once you actually talk about it, the families will say to me, thank goodness you talked about that. Because we had no idea what to do under these circumstances. And now we feel like we have the resources and the understanding to make decisions and help them decisions. But it's not just good for families. It's also good for the system. And I don't know why administrators don't love palliative care as much, because it decreases length of stays in hospitals. Earlier palliative care consults can save $7,000 to $8,000 per admission. And if you look at who's being admitted in Ontario, 40% of people admitted to hospital in Ontario are usually died within the year. Don't worry, you're not in that 40%. But what I'm trying to say is that people who are at the end of life utilize our hospital resources more than other people. And if the idea is that we want to decrease our hospitalization length of stays and the amount of hospitalizations, then that is a good decrease. So increasing home-based palliative care can avoid up to almost $380 million in costs to the healthcare system. I don't know about you, but that $380 million is our taxpayer money. So if we are actually decreasing those costs, our taxpayer money goes to better suited things. And lastly, outpatient palliative care, home-based care, can lead to 30% less utilization of acute care services. So patients benefit, caregivers benefit, the system benefits from palliative care. You're going to think I'm like a commercial here for palliative care. But like, really, why aren't people getting it? What is it that prevents people from getting it? So when I look at it, I look at the reasons people don't get it is because there are patient-related issues, physician-related issues, and system-related issues. So I've kind of broken down some of them for you. But what are the patient-related issues? Well, I don't like to talk about it for cultural reasons. I don't like to talk about it because I'm worried I won't have any hope afterwards. I'm worried you're going to promote, a decision that I don't like. Palliative care is not for me. I'm not at that stage yet because I am not dying yet, right? All these stereotypes of what palliative care can represent, patients are worried about it. Why don't doctors like it? I think I must have failed my patients because I can't get them better. I don't think I have the time to have these conversations with my patients. I don't feel comfortable having these. I don't have the skill to have these conversations with my patients. If I do talk to them about it, they're going to lose hope. And I don't want them to do that either. So that's another reason why doctors don't do it. And then there's the systemic reasons. There are limited palliative care resources. There are limited palliative care doctors. Who is the doctor that refers you to your palliative care physician? If you've got heart failure and cancer, and you have a nephrologist who's monitoring you for some kidney dysfunction, and you've got a family doctor, which one of them is going to send you to palliative care, right? And so doctors are going to sit there and they're going to be like, well, I'm not going to do that, right? So everybody is a little bit afraid of what it represents, and so everybody kind of washes their hands from it and says, well, it's not going to be. And so really the take-home message is, if you feel that this might be right for you, ask. I'd like to speak to a palliative care doctor. I know I'm not dying yet. I know there's life left to live, but I am uncomfortable for these reasons, or I want to speak to somebody for these reasons. And I know that I have a condition that may take my life at some point in the next little while. I'm going to ask for it. And I can promise you that the worst thing you could hear from a palliative care doctor, if you ask for it, is you're too healthy for me. Right? That's the worst thing you could hear. And I have said that a number of times to people. You are too healthy for me. It's fantastic that you've asked for this. This is what I'm going to recommend for you to your family doctor or your whoever is referring. But you don't need me yet. Here's my contact information. If things change, call me. Right? That's the worst thing that could happen to anybody. Right? That's the best news I could ever give somebody. You're too good for me, right? So those are the challenges. Anybody have any questions so far? Okay. So let's talk about MAID now. All right? So MAID was decision that was made through the court. The courts and the Supreme Court of Canada really kind of initiated the discussions about MAID. So the question that the courts were asked, the Supreme Court was asked, was, does the prohibition of assisted dying violate an individual's right to life, liberty, and security of person? And does it violate equality rights for people with severe disabilities? So the first case that you might have heard of about MAID was in 1993 with Sue Rodriguez, right? Sue Rodriguez was a woman with ALS who wanted to pursue assisted dying. It went all the way to the Supreme Court, and the Supreme Court, in a decision of majority decision of 5-4, said, you're not allowed. You're not allowed. So why did the Supreme Court feel this way? The Supreme Court at the time felt that the law was meant to protect vulnerable people. And if you don't protect vulnerable people, then anybody can take advantage of it. And people who are vulnerable, elderly, chronic illnesses, people with disabilities, everybody is going to say, you should try me. It's perfect for you. And so the Supreme Court said, no way. We don't trust that. So we are not going to allow you to do it. They felt that there was not enough evidence that safeguards were in place to protect the vulnerable. And at the time, the Supreme Court actually felt that equality means the same thing for everybody. We are being equal if we apply the law equally. So I'm going to give you your primary 5-minute talk on jurisprudence for MAID. In 2015, it came back to the Supreme Court. And this one was with Gloria Taylor and Kay Carter. And Gloria Taylor was a woman who, Kay Carter, I think, had ALS, and she ended up traveling to Switzerland for assisted dying. And it went back to the Supreme Court, and they said, this violates the same questions. And on February 16th, 2015, the Supreme Court unanimously agreed that her rights were violated. So from 1993, where it was a 5-4 decision, to 2015, all of a sudden, the same question, the Supreme Court unanimously said, we agree with you. Why did that happen? How could those 22 years make such a huge difference in a court decision? Well, here's the thing. There was stronger evidence from other jurisdictions. So Oregon was already practicing medical assistance in dying from the early 2000s. And their research actually showed that it wasn't actually vulnerable people who were selecting MAID. It was actually white people from, medium to higher socioeconomic classes who were educated, who were choosing MAID. They also found that there are clear safeguards that can be put in place in order to control for the impact that this could have on vulnerable populations. So that's the first thing. Second, the medical population started to change its philosophy of care. We went from a patriarchal, your doctor says to you, you do this, and you don't ask me questions, to a situation where doctors were like, what do you think about this? What's your thoughts about this? How do you feel? We went to a system of what we call patient-centered care. And we started to respect patients who made decisions that might not necessarily be in sync with what their doctor actually agrees with. We also had a number of different cases that actually looked at the law differently. So as I say here, the law applies equally to everyone. Since no one could assist suicide in 1993, there's no discrimination. But a number of legal cases happened over the time. So that in 2015, the court started to find that identical rules can have unequal effects. And we actually have to look at the effects of our rules on different groups of people to see if really we're being fair to everybody. And so, for example, there should be a law to allow for sign language in certain institutions so that people who are deaf could be, well, initially they were like, well, there's nothing for anybody. So we're not discriminating against deaf people. But eventually the Supreme Court actually found that that's not true. That we are discriminating against deaf people if we don't have sign language under certain circumstances. And so, no, we're not treating everybody equally, but the effect is that we are managing everybody equally. Disability rights groups were starting to fight for it. The baby boomers were getting older. They were of a different generation where they felt more empowered to talk about it. There was a focus on heavier burdens in certain groups so that the court started to actually recognize that sometimes the systemic problems that we're providing to vulnerable people is because of structural and system barriers, not because of their problem. They are systemically being discriminated against because we don't have ramps for them, not because not because we're treating them individually so badly. And so there was a shift from a notion of individual to a notion of the social benefit to a notion of autonomy and dignity. And so by the time 2015 came around, people were already starting to talk about MAID in a different way. So when Carter versus Canada came to the Supreme Court, there were teams like mine, I was at Mount Sinai at the time, that actually started preparing in 2014 for the Supreme Court decision to allow for MAID. Because we were already very aware of the changes in the focus, and we were fairly confident that come 2015, when that Kay versus Canada was coming to the Supreme Court, that they were actually going to rule in favor of medical assistance in dying in Canada. So what happens is the Supreme Court says this is unconstitutional. It has to go back to the legislature. The legislature in Canada, because the criminal code is a Canadian-wide issue, the legislature has to create new laws about this, and then it goes to the provinces. So the legislature creates the new laws in Canada, and the provinces take those laws and implement them. So really, it wasn't until 2016, June 16th, 2016, in which MAID was legalized in Canada. And at that time, it was legalized for people with reasonably foreseeable natural death. I put that in quotation marks because reasonably foreseeable is not defined. So what does reasonably foreseeable mean from a court perspective? Don't know. So there have been some courts that have ruled that if you're diagnosed with ALS tomorrow, you could then say, I don't want to live like this. I don't want to deteriorate. I don't want to decline at all. If I can no longer move, like if I've been diagnosed with ALS, I already have symptoms. And I don't want my symptoms to get worse anymore. This is not the life that I want to live, and I don't want to deteriorate. I want to go for MAID now. And the court could argue that that is reasonably foreseeable, even if you're still eating, even if you're still drinking, because you are still experiencing intolerable suffering. And intolerable suffering is also not defined. So what does intolerable suffering mean? It could be physical, it could be existential, it could be emotional, hard to say. So in 2021, after 5 years of testing out MAID, the government made some changes. So they created 2 tracks. I'm not talking about track 2 today. The track 2 is basically you don't have a reasonably foreseeable natural death, but you want MAID for whatever reason, and that is a much more complicated thing. Usually, palliative care is not involved in that. They need much more evaluation. It takes longer to access. We're not going there today. We're going to talk about the people who are still on track 1, which is who are reasonably foreseeable, right? And the last thing is it allowed people with a reasonably foreseeable death to sign a waiver of consent. That basically says, I consent to MAID if I lose capacity. We're going to talk about that because it's really important to understand what that means. So it allows for MAID to be given even if somebody loses capacity before the scheduled date. And then in 2024, there was a change in plans because they needed more evaluation about people with mental illnesses, so that has been postponed. Okay. So the next